In a few minutes, I'll introduce Dr. Gray, who's also with us. We appreciate him taking time. So let me just talk about kind of where the system is at right now, give some updates, and obviously this is a small but mighty group, so you can ask some questions if you want to get more specific. So, everything the last 18 months has been about COVID. So let me just talk about COVID a little bit. COVID is one of those things that, the community may be done with COVID, or we may be done with COVID, but it's not done with us. We're in our second worst surge that we have seen. You have to go back, ironically, I just looked, you have to go back to December 24th was when we had as many patients as we have in the hospital today. So we have 48 today. On December 24th, Christmas Eve, we had 50, and we were coming off of a major peak. We peaked out on November 16th, and we were coming down in December off of that peak, and we were around 140, excuse me, on November 16th. So other than that surge, this is the second worst that we've seen. It was back on July 12th that, believe it or not, we had zero COVID inpatients in the system. The last month we've averaged really between August 15th and September 15th, anywhere from 30 to the 48 that we have today. The problem is that we're seeing people come in a lot sicker than has happened previously. Our ICU percentages are much higher. Just to give you an idea, GMC Davenport has a capacity of 20 ICU beds. Today, we have 8 active COVID patients and 4 COVID recovered. It means, for the most part, they're still intubated. They just don't test positive anymore because COVID has run its course as an active virus, but it still has the effects. So that's 8 plus 4 is 12. 12 of the 20 patients we have in the ICU are COVID related. At Silvas, we have 5 patients total. 4 of the 5 are in the ICU. The ICU only has 5 capacity. So our ICUs are just full of COVID patients. It's clogging up the healthcare system. It's creating a lot of issues that are very difficult. So this is a real problem for us, and it's been very challenging. And Dr. Gray can talk about that much more specifically from a clinical standpoint. One of the interesting things that's happened, we obviously mandated COVID vaccine for our employees. After we did that, the state of Illinois required that or get tested, and then the federal government required hospitals and health systems and all people that work in healthcare, as well as employees over 100, to get the vaccine or get tested. It's been very interesting to see kind of and interact with our employees about how they feel about that. We have a little under 30% that haven't been vaccinated yet. Some of those are legitimate from a medical declination, medical exemption, and or a religious exemption. But most of those people really should get the vaccine and just have chosen not to for various reasons. And I met with one of those people yesterday for a half hour, just wrote me an email, very, very thoughtful email, asked for a meeting. And, it was one small success because after I met with him for a half hour, he was on the fence. He said, I'm going to go ahead and get the vaccine. So I can't do that for every employee because we have 1,307 employees that haven't received the vaccine. But we're trying to convince our workforce to get the vaccine. We will have to test them starting next week if they work in the state of Illinois. That's 260 people at Genesis that work in the state of Illinois that haven't received the vaccine that'll have to be tested now once a week at our cost. We have to pay them for both the time as well as we have to pay the cost of the test. Believe it or not, that right there for Genesis is over $1 million a year. So big numbers, and that is unreimbursed, by the way. So, what's interesting, and then I'll give some system updates. It's hard for me not to get on my soapbox, but when I talk with people about this, they want to talk about freedom, right? I can decide whatever I want to do with my body. I said to them, well, number one, if you work in healthcare, we're sorry. You're going to make the decision, if you work in healthcare, to get the vaccine because we have to protect the public. And the public needs to know when they come into our hospitals and our health system that they're protected because we exist to protect them. Now, we have a social responsibility, as far as I'm concerned, to take the vaccine. And let me illustrate that point. So last Friday, true story, last Friday, Jordan Voigt calls me up and says, Doug, we have 2 emergency hearts that we're going to have to send to OSF because we're out of ICU capacity, and we cannot shuffle the cards anymore to be able to figure out how to care for these patients when they come out of the OR into the ICU. And so we're going to have to turn these people away, and them and their families are going to have to go to OSF. Is that fair? You know, we have, again, 14 people in the ICU. 86% of those people since August 1 that are in the hospital have been unvaccinated. It's a pandemic of the unvaccinated. So let's just take 90% of those 14 people in the ICU, that's a big number, are there because they didn't take the vaccine. And yet these other people that needed emergency heart surgery at Genesis had to go elsewhere because those people chose, based on their freedoms, to not do that. You know, that just doesn't work for me. So I'm sorry, I'm opinionated. And because we make this work every day, and we see that the 1,000 people that have been admitted since December 15th, the statistic is 96%. Since August 1 with the breakthrough cases, it's 86%. So it is a pandemic of the unvaccinated. So some other updates that I thought I'd just give you. We, for the second time in a row, have been recognized as one of the top 15 health systems. That's a big deal because the criteria are very much quality based and cost of care based, and so we're very proud of that. We are making major investments, and this is just, I'm just going to rattle these off as quick updates. We're making major investments in Silvus right now, $20 million being spent in Silvus, updating Silvus. The OR is the biggest part of that. We're going to redo the operating room in place. We have very exciting developments that are happening with our joint venture with Wesley Life called Wellspire. The summit will open up in October. Most people that are going to move into the summit will move in November, early November 1. And the summit is the assisted living, senior housing, nursing home community that's at the intersection, well, right by the roundabout, the intersection of 53rd and Middle Road. Quite a large complex there. We're very excited about that. We're very excited about the Fieldstone, which is in DeWitt, similar facility, a little bit smaller based on the size of DeWitt. And it's ahead of schedule of what will probably be done in June or July of the summer of 22. We do have a new hospital in Jackson County. Jackson County is managed by us, not actually owned as a part of Genesis, but we consider them to be one of us. And that hospital just opened up a few months ago. It's going very well there. We're excited for that community. One of the things that's happening this next year that is a big deal, doesn't affect a lot of people, but Dr. Gray again can talk about this. There's something in healthcare called an acute care, long-term acute care hospital. That's Specialty Select. It's on Kimberly Road. We're going to bring that into the East Campus. This will benefit the community greatly, so more people can take advantage of what's called that LTAC. So it'll be on the 3rd floor. We're going to move the 3rd floor to the surgical specialty unit to the 5th floor in the new tower, and then we're going to move the ortho floor up to the shelled floor on the 7th floor. So we're quite excited about that. It'll take us a year to do all those dominoes, but that construction will start fairly soon. And then I would just mention one thing lastly, and that is we try to be very innovative at Genesis, and one of the things we're using is artificial intelligence. So computers can be made to have artificial intelligence and learn. And so we are using the concepts of artificial intelligence to automate manual work that is mostly clerical work within Genesis. And we're doing that in partnership with a company named Olive. And I just thought that might be of interest to this group. Dr. Todd Gray is to my left, one scroll down in Hollywood Squares. If you're on gallery view, there he is. Dr. Gray, yay. Dr. Todd Gray is a fantastic physician. We're very, very happy to have him. He heads up our hospitalist group. He can explain what a hospitalist is. And we thought it would be of interest to the group to hear from Dr. Gray a little bit about a day in the life of a hospitalist and ask him some questions. So take it away, Dr. Gray.
Hey, thank you so much. It's my honor to be here. So I appreciate the invite. So just a brief little snippet about me that I think is worth mentioning. I was actually born here when this was St. Luke's. So it's kind of interesting to come full circle, to have been born here and now be back in the health system. I have a couple mentors that I'd like to mention that were Genesis associated throughout their entire life. One is Dr. Mark Hall, who I believe was on the board previously. He was definitely a mentor for me. He ran the primary care practice on Division that I think eventually ended up being owned by Genesis. And then Dr. Forrest Smith, who passed away, I think, a year or two ago. He founded the residency program here at Genesis. Me and my whole family reside here in the Davenport area. A fact that not many people know, I also went through Palmer College. So I also am a chiropractor and practiced independently for almost 2 years.
I didn't know that.
And
Interesting.
What was that?
I didn't know that.
Yeah, I had my own practice for about 2 years in Moline and graduated in 2000 from Palmer. So,
wow.
And yeah, and then also I'm proud to be a United States Air Force veteran as well. So, as far as a day in our life, boy, I think if you would have asked me that question 2 years ago, there would have been a pretty standard answer. And obviously with the pandemic, that's been flipped completely upside down. I can actually remember the first few cases. It was really tough to sort of manage the team during that time because we literally were asking doctors to come to work knowing that they could catch something that could kill them. Yeah, I mean, just to be as blunt as I can. That was very difficult to keep the team focused, to keep the team patient. There was a lot of panic, even from the medical providers. So initially, a day in our life for those first few months until we had some idea of what we were going to do, how we were going to manage it, is probably one of the most challenging things that I've ever been involved in. At the same time, I was asked to be on the COVID executive committee to help design policies and procedures of how to treat COVID. I think that that was a good thing because it allowed me to give the team direction and give the team reassurance. So a day in our life, we work 12-hour shifts, 7 a.m. to 7 p.m. Our volume can range anywhere from 12 to 20 patients a day. Our sweet spot is about 16 patients. And as you know, we see patients throughout the whole entire hospital. We've attempted to consolidate that so the doctors don't have to walk around so much. So instead of maybe going to 8 different units, we've consolidated that. Maybe they only go to 3 to 4 different units. We've made multiple changes that have been extremely staff satisfying. During our 12-hour shift, we broke up our admitting blocks. So we have a block from 7 a.m. to 11 a.m., a block from 11 a.m. to 3 p.m., and then our last block from 3 to 7. That's been a humongous staff satisfier. Otherwise, the admissions come all day long. And, you know, you might get one at 7:01 a.m., you might get one at 6:32 p.m. And it was really discombobulating. And since making that shift, you can imagine once your admitting block is over, that's it. You're done for the day for admissions. So it allows us to spend more time with patients, with families, make phone calls, follow up on studies, and hopefully result in a shorter length of stay. So again, week on, week off, 12-hour shifts. Volume has surged recently. We've set record numbers for our team. We typically run 120 to 150 on our census. We broke 190 about a week or two ago, which is, I never would have imagined that we would have achieved those volumes. We had such a high volume, we had to upstaff our team. On any given day, we had 9 providers with 1 admitting provider, so technically 10 providers during the day. We now have 10 rounders plus an admitter, so now we have those 10 plus 2 at nighttime. And then our Silvis team, we have 2 during the day and 1 at night. Volumes at Silvis also surged. High volume at Silvis was probably 25 plus. When we get to 30, we start to panic. There were times we were running in the mid to upper 30s, if not 40 at Silvis. So, you know, there's been a lot of volume surges recently. So that's kind of a day in our life of, you know, our hospitalist. I'd like to follow up on Doug's point about COVID. You know, how sick are they now versus previous? I agree with Doug 100% that there's a really big divide. You're either really sick, you're in the ICU on a ventilator, or you're kind of not that sick. The not so sick ones, absolutely 100% are the vaccinated ones. I've never seen such a clear divide. I can almost guarantee you if they're that sick and intubated, I don't even really need to check. I can pretty much assure you they're not vaccinated. Even elderly people with multiple medical problems, if they do get COVID and they've been vaccinated, the course is much less severe. I mean, it's extremely striking. But to Doug's point, it's also very frustrating because these are the same people that, will run to us when they get sick and want to be treated, but don't want the vaccine, which clearly can help them not be sick. It is a little frustrating to the people that are doing everything they can to stay well and to occupy a bed for 10, 12, 15, 30 plus days. So that's kind of a quick little summary of what a day is like in our hospitalist life.
Thank you, Dr. Gray. And you said something interesting about the volumes, and we count the number of current COVID patients and patients under investigation because we believe they are COVID. But you're seeing an uptake. Are you seeing a lot of patients who had COVID previously coming back into our hospitals is that part of the increase that you're seeing, or can you categorize what you're seeing?
So interesting question. And I can assure you behind the scenes, this has been heavily debated and talked about. I personally think one of two things without having any proof. I think that I think the non-COVID related admissions, maybe they had COVID last year, didn't know it, maybe they didn't really have any symptoms. Could this be post-COVID complications? 100%. But the problem is I can't prove that because now if we test them and they're negative, I can't say that they had it. Could you do an antibody test to check to see if they were exposed? You could. Admittedly, that test is not real accurate, and it doesn't tell me the severity of the disease that they have, nor does it tell me when they had it. But I do think there's a pool of us that are starting to be a little bit concerned about COVID can affect every organ in your entire body. That much has been proven. So people with multiple medical problems, could this in theory be complications from COVID that they possibly had last year? Absolutely. The other thought is that, well, are these people that neglected their care for the last year because they were so scared to go out? Maybe they didn't see their doctor, they didn't keep up with their routine health screenings, and their chronic medical conditions worsened over the last year because they did not keep up with their care. I think that that's also a reasonable thought. What I am more concerned about is the hospital having such high volumes. This should be kind of our slow time. And here we're fixing to come into our busy time, which is the fall and the winter. Something's going to have to change because otherwise we're going to have, bigger and bigger and bigger problems as far as space goes and staffing goes.
Yeah, I was also interested in your staffing model and the ability to actually have that number of physicians available for our hospitals. What a blessing for us. And how hard are hospitalists to come by?
Well, lucky for us, we've managed to have, I'm really super, I'm going to completely brag about the team. I'll be transparent with y'all because I think that we are completely blessed to have the group that we have. We have an abnormal group in the sense that we have very little fallout. We have very little turnover, which is markedly abnormal for hospitalists. Of all the specialties, hospitalists tend to have pretty high turnover for multiple reasons, whether it's pay, whether it's family, whether it's dissatisfaction, you name it. Typically you're talking 10 to 20% turnover in any given year. So if we're a group of, say 30 core providers, we could be looking at 3 to 6 turning over every single year. Right? That has absolutely not been the case with our group. So, I just think that we have a special team of people, and I'm going to tell you a special situation that came up, again, to completely brag about the team. We had a young provider, unfortunately, get diagnosed with a malignancy and is currently out receiving chemotherapy. As a team, we decided every single one of us was going to donate a day's shift pay to this provider and give it to him and his wife and his newborn child. And every single person on our whole team donated a day's pay. And we delivered it to him.
That's great. That's great. Anulka, I'm going to ask the doctor a question. I just heard my doorbell. I'm very interested as we get going further talking about hospitalists, about the relationship your team has with the primary care physicians. I know that was of concern early on.
Yeah, absolutely. So good question. I would say, again, I'm all about transparency. I think there's always room for improvement. When we were Apogee before we merged with Genesis, we had a practice in place that every discharge summary and the hospital notes were faxed and sent to the primary care providers. So what I can tell you, our current practice is every patient that gets admitted and discharged, gets at least the discharge summary sent directly to the primary care provider, no matter what system they're in, no matter where they're at. Is there room for improvement with communication with the primary care providers? Absolutely, completely, 100% yes. I think that this topic has come up at a difficult time. Obviously, with COVID and volumes surging, our time is at an all-time, we are just stretched beyond stretched. So I think that once we get through this pandemic, I absolutely do feel that there's room for improvement with communication with the primary care providers. But right now, it's just a time-sensitive issue more than anything.
Good timing on my part, I think. There's a dog, a doorbell, and a refrigerator repairman. Talk about chaos. You must feel a little chaos in your day, though, because you're shifting patient to patient to patient. So as an internist, obviously that works to your favor. You're seeing so many different things, and you're diagnosing and treating and obviously trying to get people moved out of the hospital, which would be their concern. Can you comment on that?
On what again?
The unpredictability, all the different things that you're seeing.
Yeah, so I would say that's actually part of the lure of the job, actually, right? Is we like different, right? We don't, when things get a little repetitive like anything else in life, that's exactly what it becomes. It becomes repetitive. I'm not saying that that's not exciting and that it's not important. As internists and hospitalists, one of the things that drives us is those sort of exciting or needle in the haystack cases, right? So we are known to be investigators, we're known to be detectives, but we like that, right? So the wide array of things that we've seen recently actually makes us quite happy. And it's something we kind of crave, actually.
Well, good. So when I ask you questions about something being typical, it's really not fair because most of your life is atypical.
I would say yes.
And by the way, the reason you have such a great team, I've heard often, is because they have a great boss. So kudos to you for getting that team in place for us and our community.
I appreciate that.
Sure. Denise Eilers is with us today, Dr. Gray. And so since we're a small enough group, I'll just introduce you. And Denise is a registered nurse. She sent us a question in advance. She's very schooled in the issue of kidney disease and hemodialysis, and actually was helping her husband receive hemodialysis in their home. So she's a pro. Her question: how well informed is the overall staff and hospitalists at Genesis about dialysis and the protocols that should be in place, including not doing blood draws or taking blood pressures in an arm with the dialysis access? And is staff aware that both peritoneal, sorry about that, dialysis and hemodialysis can be done at home?
Yep. So really good question. And I would say, I think that the answer is probably going to be 100% of the staff are, number one, familiar with it. They have a fistula, which is, for the layman, it's what we dialyze through, but it's actually a vessel in the arm, right? So I would say 100% of the staff are aware you can't do anything with that arm. Once it has that fistula in place, she's exactly correct. You can't do anything with that arm. I would say that all of the staff are aware of that because we have a big dialysis population, actually. Are we aware of the fact that you can do dialysis in whatever form at home? Absolutely, because we admit these patients pretty frequently. So it's more common for us to probably admit the peritoneal dialysis patients. They often have catheter complications versus the hemodialysis patients. But yes, we are 100% aware of the arm and not doing anything with that side and the availability of dialysis at home. I would say if you were to query the staff, it would probably be 100% answer and acknowledgement that we're aware of both of those.
Denise, I hope that answered your questions. Do you have any follow-up question?
Yeah, it really does. I just really want to give kudos to I actually last January had to come in, was there overnight.
Denise, I'm sorry, Denise, you're not coming through clearly. Can I ask you to?
And the person, it was not a doc, it was a PA or whatever, actually did ask me if there were any reasons.
Denise, Denise, it's Missy. I'm so sorry. You weren't coming through clearly. Could we ask you to put your question in the chat box?
Yeah.
And maybe
Can you
go
hear
ahead
me
and
now?
mute your phone. If you would mute your
Oh.
phone.
I think it's my internet.
Yeah.
Oh, shoot.
So sorry
I
about
don't
that.
know.
If you mute and put your question in the chat box, I'm sure we'll get it answered. Great, thank you. Dr. Gray, I remember when we introduced hospitalists at Genesis, and I remember the uproar in the community because we were taking away some individuals' favorite physician.
It is unmuted.
And
I don't know. Okay. Okay.
Sorry, Denise, we're still having issues with your communication.
Anolka, you can actually, as the person who runs the meeting, you can mute the person.
So Dr. Gray, there was an uproar because people weren't comfortable with the concept of not having their own physician come into the hospital and take care of them. And that's where the relationship was. And I'm just wondering, given the very limited time that you have from the time that you admit, do your diagnosis and get people on their way, how do you build that relationship with them? Or is that a necessary part of what you're doing?
Yeah, so, yeah, I mean, excellent point. So first and foremost, building that relationship is crucial. I mean, it has to be a foundation of what we do, right? Because if you don't get the patient to trust you or have buy-in from the patient, you can be the most knowledgeable doctor on planet Earth. If you really don't connect with them and establish that trust, my observation has been over time, the outcome's not going to be as good. They're going to have more complications. They're going to stay in the hospital longer. They're going to be more frustrated. They're going to be more upset, which actually has a negative effect on their immune system, right? So when you're under stress, there are certain chemicals and hormones that get released that cause a suppression to your immune system, which delays healing. If they're diabetic, it raises their sugars, on and on and on and on. So building that foundation, first and foremost, to answer part of your question, is key. Secondly, I've been lucky enough to be in medicine long enough to see the switch over from exactly what you're talking about. So when I trained in residency at the Medical College of Wisconsin, the hospitalists were just starting to kind of come on, right? They really hadn't taken hold yet, but it was just starting to kind of grow. I've worked in rural Iowa prior to coming to Genesis, and I would say that I practiced traditional medicine. So I ran a full clinic, seeing 50 to 60 patients a day. I would also have a full hospital load of 10 to 12 patients that were my patients. I would take ER call for my patients, and then I would take nursing home call and hospice call for my patients. So I've done the gamut of everything, right? And now just hospitalist. And I would say the benefit is, number one is if you do something every day, all day, the outcomes are better. So what we found was that if you have doctors that are practicing hospital medicine every day, the patients are safer, they have a shorter length of stay, there's less complications, and the outcomes are just better. And I can tell you that if you don't actually practice hospital medicine on a regular basis, it very quickly disappears, and you very quickly will lose that knowledge base, and it's very difficult to get back because hospital medicine is completely different than outpatient medicine. So I think that the shift has been a good one, and it's safer for the patients. Now, how you establish that trust? Well, I think that that's provider dependent, and if I had a magic formula or answer for that, I would be worldly famous. I think that the best thing we can do is what I like to do. You pull up a chair, you hold their hand while you're talking to them, you look them in the face, and you stay there until their questions are answered. Do I think there's a magic formula to establish trust? Absolutely not. I do not think there is. But I think that you can care for that individual like it's your own family member laying in that bed. And if I had to pick an answer or a key that's the foundation, it would be that. You treat them with dignity and respect like it's your family member. You can never, ever go wrong. It's impossible to go wrong if you really, truly take that approach.
Wow. I think that's amazing. On the flip side, and thank you for being so compassionate and caring. On the flip side, you then build a relationship with patients that move on. If you were still in your practice, these would be individuals that perhaps you'd see for an annual checkup, or maybe even you would have that person and a spouse and children, and you would get to know the family. So tell me how you let go and let those individuals come into your life while they're in the hospital and then disappear. I think that would nag at me a little bit.
Yeah, so I think at first I'll admit that probably did a little bit, but again, having been on both ends of the spectrum, you know, everybody has a role to play, right? So I'm not necessarily up to date with the outpatient screenings that need to be done. So they really want somebody that's up to date with that, right? They want somebody that's going to be able to take care of that component of them. You know, on the flip side, I do have the benefit of, which you don't so much have in the outpatient setting. They come to us when they're at their sickest point, and we get to fix them, we get to help them, and we get to see them get back to good health. That in and of itself is rewarding. In the outpatient setting, you don't always get that. I mean, you manage chronic diseases for the most part. Now, you may have some ups and downs, and you may have some wins and losses as an outpatient, but for the most part, on an inpatient, the way I choose to let go of it is, I get to them when they're their sickest, I help them, and we get them better, and I get the luxury and the privilege of handing them back off to their primary care provider, knowing, hey, they came to me at their sickest, man, we rocked it out, we got them better, awesome for us, right? And that's kind of how I explain it to patients, actually.
That's interesting, and I love the way that you're managing that. Kind of an aside to that, which I never really thought about before. If there are patients that return to our hospital on a frequent basis, are they assigned to the same hospitalist that may have had them in previous occurrences?
Yeah, so no. Do we have them sometimes request? Absolutely, yes. So we work on a rolling admission schedule, so it would be really difficult, if not impossible, for us to start making exceptions intermittently throughout our cycle, because we are a large volume admitting group. We typically average 20 to 60 admissions every day, not just like, you know, every other day or once a week. That's every day. That's how many. I think yesterday was 40s or 50s that we admitted, but that's pretty much the standard every day. So with that volume of people coming in and probably averaging 40 to 60 discharges a day, the volume of in and outgoing patients, it would be difficult to sort of say, you have so-and-so, they were here, they requested you. That becomes extremely difficult.
I can see that. I have a comment from Denise, and Denise, I'm so sorry we didn't have a great connection today. She says, I was in Genesis briefly in January, and the ER personnel did ask me about any reason that they could not take a blood pressure in the arm. Kudos to them. So, and Doug and I will make sure, Denise, that those kudos get passed along. So
yeah, that's great.
I have to ask you, you used the word gratifying, and if I could get it in 1 or 2 words, what would be the most gratifying aspect of what you do?
1 word: patience.
There you go.
So because without the patients, we don't exist. Without patients, we don't have a job. Without patients, I'm not in this career, right? So I chose this career for one reason only, and it was to save lives and, you know, help those around me live the best life that they can. So I have this working theory that the most precious asset any of us have, that you have, that I have, that Doug has, is your health. It is your most precious asset. Why do I say that? Because if you don't have good health, I don't care how much money you have, I don't care how much stuff you have, you can't enjoy it. If you don't have good health, you can't travel, you can't see your loved ones, you can't do any activities, you're not going to enjoy life. So unless you have that asset functioning at its peak, nothing else matters. And where I get flattered, and what drives me on a daily basis is those patients come and they say, here you go, Todd, this is my most precious asset. I'm giving it to you, and I want you to take very good care of it. I don't know of anything that could be more flattering. So, you know, to have people who don't know me to come and say, Todd, this is I cherish this asset. Please take good care of it. I'm going to trust you with this. Here you go. And they willingly hand it over to us on a daily basis. I can't think of anything more flattering.
That's wonderful. We did have a question from Doug Holquist. How do you and your team stay on top of your game when working 12 hours? And what about burnout?
Yeah, so number one is, of course, there's continuing medical education, things that we have to do to maintain licensure. We're fortunate enough to have a team that's all board certified, which means that there are certain requirements we had to go through for testing purposes to all be board certified, which is kind of special because there are institutions that exist where not everyone is board certified. So there's that, and then you have to maintain your board certification. We get relicensed through the state of Iowa. I think we work on 2-year cycles, And again, the state of Iowa mandates that we have continuing medical education credits. So it's not really a choice for us to sort of stay up on our game. It's a must. It's a must. But if you ask any of us, we're lifelong learners anyways. So if the state of Iowa says you need 20 credits, I can assure you, with all the reading and the stuff that we've done, we far surpass that every single year, just to stay up to date. When we retained Apogee on for administrative purposes, they also help us with staying up to date. So Apogee is a very large coast-to-coast throughout the whole United States hospitalist company, and they will routinely send us hospitalist updates because I thought that would be an advantage to say, well, what's going on in California or Florida, or how are those hospitals being run? How are they treating X, Y, or Z conditions? And knowing the regional director for Apogee has allowed us to sort of, if we need to shift or steer in a different direction, has certainly allowed us to keep in touch and keep our, finger on the pulse of what's happening in the latest and greatest in hospitalist medicine. Avoiding burnout, I don't know if there's necessarily a way to avoid burnout, but what we can do, which is what our team does, is we all stay in close communication with each other. We check on each other. We have a group site, a WhatsApp site that our team has that only team members have access to. That's our venting area. That's our question area. That's our, hey, are you okay area. Have I personally made phone calls and text messages to people outside of that? Absolutely. I mean, I've lost track of how many times. So the best thing that we can do is identify, go to that person and say, hey, are you okay? And if not, have we made and, shifted around our schedule to get people time off? Absolutely, right? But avoiding it, I would say, is probably next to nearly impossible if you're passionate about your work and if you're really involved in the process. Kind of comes with the territory, unfortunately, right? I don't think you can avoid it, but we can certainly pull together as a team to help it as much as we can.
That's a great answer. I know that we've asked you to look at what's happening now, and we've talked a little bit about what's happening, what has happened over the last 18 months. We have to look to the future. It's different. Practicing, I'm sure, for you is different right now. And I'm just wondering if there's anything that you took away from the last 18 months or innovations that were introduced, whatever the case might be, how that's going to impact your work going forward. What's it going to look like?
Yeah, so I think that number one, I think to be transparent is that we don't know. Yes, I'm not being vague. I'm just being honest and saying we don't know, because the thing that we don't know is the long-term impacts of this disease, this horrid disease, right? We don't know the long-term complications. So I think one thing that we can probably expect is that it probably will continue to change and it will probably continue to evolve, right? Just because we're seeing sick people now doesn't mean that we won't continue to see sicker people from COVID a year from now, 2 years from now, 5 years from now, 10 years from now. So I am a firm believer in that. I think we have just begun the change that will likely come, right? I think that there will be further changes to come to how we practice. I think this will be a full-on game changer to how we practice medicine. COVID and exposure to COVID, even if it's 5 years from now, will probably have to actually still be in our mind somewhere. Did you have exposure to COVID 5 years ago? Did you have COVID? What does that put you at risk for? I really think that it might change what diseases we look for, the complications that can happen to somebody. So I still think there's a lot to come of how we're going to possibly have to practice in the future, actually. Now, masking, for me, that's probably been one of the biggest changes, right? I'm in a mask more than I'm not in my personal life, right? 12 to 18 hours a day is spent in a mask. Well, again, there's very little time not in a mask. I think masking will continue to be a part of our future for the next several months. I'm not even really sure when that mandate will probably drop from a health system perspective, just to be safe. So that's obviously a change for us as well.
Well, hopefully that'll help us during the flu season as well. We've got 2 minutes left. I have to ask you about your transition from chiropractic to what you're doing now to become an MD. Why? Yeah.
So I have a really easy answer. So my practice was starting to get extremely busy, and I was, doing very in-depth physical exams and question and answer sessions. And one of the things I always went over was their medication list. And time again, I would say almost every time, the patients would say, well, can I come off of this medicine? Can I come off of that medicine? Can I come off of that one? And I said, I have no idea. I have zero idea about that. And it started to kind of get to me, started to kind of drive me crazy. So I said, you know what? I'm going to make a huge sacrifice. I'm going to drop this successful practice. I'm going to go back and learn as much as I can about medicine so I can answer these questions. And that's exactly what I did. Unbeknownst to me, my life had another path waiting for me. During my residency, 9/11 made a big impact on me. And so during my residency, I signed up to join the Air Force, which was quite unexpected. So I started off with, wanting to know as much as I could about medicine, and then ended up actually in the military for several years. So that was unexpected, but, still something I'm extremely proud of. So, but that's what originally drove me to go to medical school.
Well, we're the better for it. So we thank you for all your service, and we thank you for being with us today.